Hello, everybody, and welcome to the Neurotransmitters, a podcast about everything related to clinical neurology with the goal of reducing your neurophobia. I'm very fortunate today to be joined by Zachary Grin, a doctor of physical therapy, with some unique focuses in his practice. And do you go by Zach or Zachary?
Zach's good.
All right. Hey, thank you so
Yeah.
much for joining me this morning. Would you mind starting us off just a little bit? How did you wind up? I know physical therapy is a very unique and attractive field, but what was it that brought you into it?
Yeah. Well, I wanted to say first, thank you so much for having me. I really appreciate this. Yeah, I really like the fact that I get to help people, but also I'm there for their like entire recovery journey, really. So it's not, 10, 15, 20-minute appointments, and I'll see him again in a few months. Some of these people I'm seeing 3, 4 times a week, sometimes once a week. And I really like to be able to connect with people.
Yeah, that is that longitudinal aspect of care is certainly attractive, and I know at one point in my training I was very attracted to the rehab side of things, but I got drawn away to neurology at one point. But so where did you start your training?
Yeah, I graduated from Clarkson University. It's in upstate New York. Um, that's where
Okay.
I got my doctorate degree. And then, do you want me to go into like afterwards?
Yeah.
Yeah, yeah. So I started working at a hospital system here in New York City for a year, about a
Mm-hmm.
year, and working in the hospital outpatient. Um, and then I decided to open up my own practice.
I know, we kind of met online on Twitter, and we've been kind of running in some of the similar circles in terms of like functional neurologic disorders and things maybe adjacent to that. Now, in my experience, and probably I'm going to guess in yours as well, a lot of traditional physical therapy treatment plans may not be the best suited for those types of people. How did you initially kind of make the connection and then kind of tailor your practice to that?
Yeah, so I really started my practice for people with functional neurological disorders. So I kind of right off the bat, um, my business plan, my way of practice was tailored to this already. When I was working in the hospital, yeah, it was very different working with
Mm.
other patient populations. Um, the biggest change was learning to not talk so much to to people. So we tend
Yeah.
to really want to help people really do like corrective exercise, make sure they're doing the exercises correctly, good
Hmm.
form, and we do a lot of education and talking in terms of the exercise and how people are moving their bodies.
Hmm.
That doesn't work for people with FND
Yeah.
typically,
Okay.
and and it does make them worse a lot of the time. So
Hmm.
um, unfortunately, most of the people I see with functional neurological disorders right now, I'm the third, fourth, maybe even fifth physical
Right.
therapist that they've seen, and they're always a little skeptical, which is completely normal because
Yeah.
they've just
Yeah.
had so many trials of this more. I guess you could say traditional physical therapy. It's, I guess, hard to define what traditional means, but
Hmm.
in the sense of this very body attention, like focused
Hmm.
way. Yeah.
And what kind of things have you found in, both in the literature and in your own personal experience, tends to work best? And I know, FND is kind of an umbrella term, when we have so many different subtypes of it.
Yeah. And it really does depend on the subtype. And
Hmm.
so for people with like a functional movement disorder, whether that's tremor, a gait disorder,
Hmm.
dystonia, um, it's really helpful to have this what we call like an external focus,
Hmm.
an external attentional focus, and that can be anything. Sometimes it can be like just thinking about it. Other times we're actually using stuff. So I can, tell somebody to imagine kicking a ball while they're walking. So someone with a functional weakness that can't progress their limb forward,
Mm-hmm.
if they are thinking about progressing that limb forward, they're not going to be able to, and it tends to get stuck. And it usually
Mm-hmm.
gets stuck in a very specific way, which is a positive rule and sign for a functional
Right.
movement disorder. But um, that increased attention to it makes it not want to move. And so what I do is, for example, I'll have them think about kicking a ball forward, and boom, that leg will just swing right forward. They're able to walk if they don't think about walking. Now I might
Interesting.
also put a ball in front of them and actually have them kick the ball too. It kind of depends on what equipment we have at the time, and depends on the activity. But yeah,
Very cool. So yeah, that does kind of mirror what we would think in terms of it's more of like a task specific kind of problem for many like the functional movement disorder types of patients at least.
exactly. Yeah, task oriented, goal oriented. It has to
Hmm.
really be focused externally. Yep.
Gotcha. And would you find that in your practice it's mostly functional movement disorders, or have you had other flavors of FND as well that you've been incorporating?
Yes. So I've had some people with 3PD or functional dizziness,
Mm-hmm.
persistent postural
Oh
perceptual
yes,
dizziness.
it's a mouthful.
Um, yes, it is. 3PD's good. And
I haven't heard that
so,
one before. I like that.
yep. And so that's so functional dizziness that definitely takes on, you know, the treatment principles are similar though.
Mm-hmm.
It does obviously look different in terms of the dizziness. So, we're looking at vestibular function, ocular motor function, somatosensory function, and we're still having that external focus. Another one of the treatment principles is really like that I use is like sensory input too.
Mm-hmm.
So a lot of the times people find certain sensory input, whether that's weighting, vibration,
Mm-hmm.
some type of tactile sensation, can really help kind of modulate their movements or even dizziness as well.
Okay.
Um, yeah, and then go ahead.
No, I'm sorry, just clearing my throat. But I find myself in a similar boat where I'll see these folks, and you do your assessment, you do your Dix Hall Pike, all of your kind of gait evaluations, and if someone coming, like you said, I'm like the third neurologist they've seen for dizziness. I'm like, well, you've kind of been through the ringer, and then you wind up, and I'm sure these people show up on your treatment schedule as well, where they're maybe they're on chronic benzodiazepines or meclizine for
Necklacine,
you. I know it's the bane of my existence. Like it
same.
doesn't even work that well, even if for
Yeah,
legitimate vertigo. But
yep.
but you have all these people, and then they've, like you said, they kind of develop these maladaptive behaviors, and um, it's really hard to find. I shouldn't say really, but it's, let's just say, challenging to find a skilled physical therapist who has more than one protocol for like dizziness, if you will. Uh, but I know you mentioned some of the things with like oculomotor retraining. Does it depend on like what kind of flavor the dizziness manifests itself in with the 3PD type folks?
Yeah, it can be, and really, it's about like on the surface, it doesn't seem all too different, but
Mm-hmm.
like a typical like retraining for like vestibular ocular reflex and stuff is really just like sitting there,
Mm-hmm.
finger held out, and you're turning your head back and forth, right?
Right, right,
Like those types of activities, it's still really body focused, and you're
right.
looking at like a certain body part, and so those types of things make people worse typically with 3PD. And so it's
Mm-hmm.
more the same. We want to get that same type of input and that same type of training, but we
Mm-hmm.
want to do those things with like externally. So that might be throwing and catching a ball. That might be, anything that really is kind of fun. Like
Gotcha.
play fun is a really
Mm-hmm.
important part of it too. That we're not just sitting there doing these exercises, and they should be meaningful to the
Mm-hmm.
person.
Gotcha. And I imagine those people have a lot of gait disability as well, typically.
Typically they do, yeah. And
Yeah.
it's typically a very more like rigid,
Hmm.
kind of some block turning going on and really looking like they might fall over if they don't do that.
Yeah.
But there's that internal inconsistency where other times you won't see that at all. And the gait's actually pretty good and pretty normal. But if I ask
Hmm.
them to walk and do things, they start to really tense up.
Gotcha. How do you tend to help them overcome that in that particular patient population?
Yeah, so that comes with a lot of education, lots
Hmm.
and lots of education.
Yeah.
And without having a proper understanding of these functional neurological disorders, it's really it's really hard to implement these other treatment strategies. You have to really be
Hmm.
able to explain the diagnosis to them,
Right.
and they have to really have a good understanding of that diagnosis.
Yeah.
Um,
And it does seem, and this has been my experience. I'm just curious if you've noticed the same thing, where like if you are, say, nth number healthcare worker that they've worked with down the line, and they've seen like all these doctors or other members of the treatment team who just say like, oh well, we don't really know what's wrong with you, and they kind of get like pushed and pushed and pushed, and they just kind of wind up not getting any help or getting maybe things that medications that aren't helpful, or they put through physical therapy that again is more body awareness in necessarily the wrong kind of way. How hard is it for you to, to basically explain things like this is what it is and this is a plan that has a good chance of helping you?
yeah, it's a great question. It really depends on the person,
Yeah.
and it can vary greatly.
Mm-hmm.
Um, you have to you have to kind of gauge the person's reaction to it.
Mm-hmm.
There are some people that that's just not where they're at right now,
Mm-hmm.
and trying to kind of force force it on them almost of like, no, this is what you have. Like that just we're talking about people's beliefs, and it's really hard to change that or influence that,
Right.
depending on kind of where they're at in their stage of recovery. And so there are some people that I just had to kind of refer back and say, I don't think physical therapy is the right time right now, because without that, it's really hard to also do these treatment strategies that we're going to be doing throughout the episode of care. And without somebody's full commitment, we're talking about changing brain connections here, neuroplasticity. Like you have to be fully committed. You have to do this repetition after repetition all the time. And without that belief, it's really hard to do that. Um, Other people, though, it makes perfect sense to them, and that's the norm. From what I've found, that most people, it they often tell me, I feel like I'm finally in the right place, and that's like
That's awesome.
really resonates with them and is what they've been looking for.
Very cool. How now? I know one of the things that we see a lot, or at least hear a lot about in folks with different types of FND is if you, let's say you've gone through a successful treatment protocol with somebody, and like so many of us, you kind of fall off the wagon with your exercise regimen. And how often are you seeing people coming back after like reemergence or kind of like doing like a re-education session or things like that?
Yeah, so I'll typically depends on the person, but I'll typically schedule maybe like a 3 month or even like 6 month follow up. Um, just to do like an evaluation, check in, make sure everything is good. I find most people don't feel really confident after going through treatment, because the whole idea is I'm giving them the tools that they need to self manage this, and almost universally that's been what people say is the most helpful thing. They feel a lot more confident
Mm-hmm.
in their ability to manage their symptoms, and it's all about regaining control, because at its core, FND is this kind of loss of self agency
Right,
and
right.
control. So you have to reestablish that, and once that starts to become reestablished, it's it's life changing for people, really, and they often are able to go on with life with that.
That's awesome. Yeah, people underestimate how disabling some of these symptoms can be, especially I think on the medical side of things, where they're like, oh, it's all just in your head, so to speak.
Mm,
Um,
yep.
but yeah, I mean, if you look at all the data, right, like the number of days of work lost, for functional or dissociative seizures, the risk of morbidity and mortality is comparable to someone with refractory epilepsy. So it's not okay just to kind of brush these people off, especially when there are legitimate treatment options that can help them get better.
Yep. And I
Um,
do
yeah,
always recommend they continue to follow up with typically
right.
the referring provider is usually for
Hmm.
me a movement disorder specialist,
Oh, excellent.
because we do want longitudinal follow up of
Hmm.
people with this just to ensure the diagnosis is stable, make sure nothing's changing in that regard.
Right. There is that. There is data that again, these kind of poorly defined nebulous groups sometimes the numbers shift a little bit, like anywhere from 10 to 20% of people with FND may also have a concurrent neurologic or other type of disorder. So, you do have to keep your antenna up for something else declaring itself down the line.
Absolutely. Yep.
Now you said you work pretty closely with some of the movement disorder specialists in New York City. How did
Yes.
that relationship develop? I mean, other than being one of the only people who specialize in it one of the biggest cities on the planet.
Yeah, yeah. Um, Mm, Pretty much through the patients themselves, actually, is where it started. So I kind of put my name out there on the F&D Hope website and their provider lookup tool. And yes, I am the only physical therapist on there in New York City. So anytime people go to there, they do get me. And so really, I've been connecting through to the referring providers through them. And I've established a really good relationship with one of them at a large hospital system here. And that's kind of spilled over to me now giving lectures on FND to their movement disorders, like multidisciplinary clinic.
Excellent.
Um, and even working with like a local Parkinson's disease foundation for people with functional tremors and with PD as well.
A
Um,
very challenging population.
it is, yes.
And how did you go? Because I know the shift from like, I work in a hospital primarily, and I had one attending. He was a former physical therapist before he went to medical school, and he
Mm,
not so kindly referred to inpatient hospital PT as ambu-dragging.
yeah.
Um, and it is. There's a lot. Like you got to have some good upper body strength, especially for like those people who just had a stroke and things like that. But how does one go from that to kind of this much more nuanced practice that you've built?
Yeah, it's very different and it's still challenging. Sometimes I sit there and think like, am I still doing PT? Am I still a PT? I get it because it just doesn't feel like that sometimes. Because yeah, you get so used to the hands-on treatment, and really you don't want hands-on treatment for people with FND. That's the other big change that I didn't mention is this all has to be internally generated. I'm more of the guide in this, and yeah, it's challenging, but you get comfortable with it, and you
Hmm.
also see that you are making a huge difference, and that it's necessary to properly um, provide these people with treatment.
Awesome. So, in terms of like I say, a standard PT curriculum, where does the management of FND come in, or where did you learn about it? I know in my own career, we had some kind of surface level exposure to it, but a lot of it was not necessarily getting into the weeds in terms of like what do you actually do, how do you provide optimal care for these people.
Yeah, yeah. So in our neurologic section of PT school, we did some like students ran like presentations, and one group had conversion disorder, and this was only like 2 years ago, really, 3 years ago. And so
Right.
I had looked at, I've heard of it before, like when I was on a clinical rotation too, at a hospital, and a patient presented with functional seizures. But so I started looking up a little bit more then, and I was like, oh, it's not really called conversion disorder anymore. And that was kind of the first time. And I even kind of spoke up during their presentation because it was all based on like DSM-4 criteria, and it seemed outdated. And
Right.
everyone's kind of like, okay. And then we kind of just like moved on. And so I started kind of researching more and more about it, and I found it fascinating. And I'm like, why is everyone not fascinated by this?
Yeah, yeah, it is, kind of that that stigma that's stuck to it for over 100 years. But yeah, it's like one of the most neuroplastic type things that happens all the time.
Yeah.
It is. I agree with you. I do think it's fascinating, and why don't we have better evidence? And it is just that lag in interest in the medical community at large. But
Yep.
thankfully, that seems to be turning around at this the last couple decades.
Yes.
So you mentioned functional seizures as well, which I have a personal interest in, having worked in the epilepsy sphere a little bit more. Are there protocols on the physical therapy side that tend to help with those dissociative events as well?
Yes. So officially, no, not really. Um, the reality is, most people don't have just one specific type of
Hmm,
functional neurological disorder.
that's a good
I've at
point.
least rarely have come across that. Typically, people that I see that also have functional seizures also have like motor and vocal tics as well, and even a functional gait disorder, functional tremors, the kind of the whole thing. And so I think we need to address that. I don't think you can really fully treat someone with just focus on this. This provider is just going to focus on that. I feel like all providers need to focus on everything. And they need to focus on the person, really. And
Right.
um, so I've tried some things out with people with functional seizures, and I have this patient right now. Actually, they're doing so awesome. I'm so proud of them. They're 3 weeks now seizure free, and the first time in a year. And all it really took for her was to really identify this like pre like sensation that she typically gets before having a seizure. And then we use a distraction technique. So distraction, just not that external focus, but also distraction away from the symptoms. And so I kind of work with them on things that they like to do. And she likes to whistle. We noticed, when we're working on gait training, whistling completely resolved her gait disorder in that moment when she's whistling.
Fascinating. Yeah.
So she went out on her own, bought a whistle that she wears around her neck. When that sensation comes on that she's about to have a functional seizure, she starts whistling a tune with it, and she's totally able to suppress it and not have it occur.
Fascinating. In terms of that is very, because I think back to a patient I had in my previous practice before I moved, and she had a diagnosis of POTS, floridly positive, occasionally needed to use a wheelchair when the flare-ups were particularly bad. But she came to me for spells, and so I brought her into the epilepsy unit, and we captured some spells, and they were it was kind of like a pseudo syncope, quote unquote, if you will, and with eye fluttering and all that kind of stuff. And we did have a recumbent just to make sure that we weren't seeing any drops from the pots or things like that, and blood pressure. But she ended up sticking with me for her pots, and I had some exposure to it in training, but I'm not necessarily an autonomic specialist per se. It was more just that I tried to learn more, which
Yeah.
unfortunately for so many doctors in particular, it's not something everyone gets very siloed, a little bit balkanized, and they're not really wanting to step outside of that area. But I was fortunate. I did have a little bit of training in my fellowship, so I was able to maybe stick my toe into the water a little bit. But yeah, sometimes some of the things that you do, like you said, the evidence isn't necessarily there in terms of the treatment strategies. Um, so you're always kind of straddling that line between I want to help this person, but I also don't want to necessarily be too aggressive and potentially cause harm to them, and that becomes
Yeah.
sometimes a bit of a dicey line.
Yeah, and I think that's where communication with the rest of the healthcare team is also really important too. So, typically the gold standard treatment for people with functional seizures usually psychotherapy, and so I speak to every person's psychotherapist. We kind of sit down and have a talk, and none of them have ever heard of FND, and even like conversion disorder weren't even really like too
Yeah,
familiar on that, which I was surprised about. So
right.
I'm typically sending them resources, literature, and everyone's been super open to learning more about it, which has been great. But yeah, I think that's kind of pulling in the other team members becomes really important in that case.
Yeah, and that is something that I also find somewhat surprising is that our colleagues more on the mental health side of the care spectrum, it is, you know, conversion disorder from the DSM-4 or FND now. Uh, it's not something that necessarily they have a lot of experience or exposure to treating that, and that always just boggles my mind. It's like I see it all the time. It's like do these and like I can only imagine that because to your earlier point, do they have the insight? Do they have the understanding of the diagnosis? And if the person who diagnosed them, I'm making air quotes here, uh, did not communicate that effectively, then they're like, I don't have, functional neurologic disorder. I have some unexplained rare disorder that I need to undergo further testing for because this doctor didn't figure it out. And I find that that's all too common.
Very, very common. Yes. So I'm hoping to change that with with educating others, and
Yeah.
I have no problem explaining the diagnosis a lot. Like it's one of my favorite parts actually is really educating on it. But you know these things need to be reinforced over time too for some people, and having
Right,
all
right.
team members be at that level of being able to really effectively communicate that is super important.
Absolutely. Yeah, a concordant message amongst all the team is good. You don't want to go to
Yes.
your psychiatrist or therapist and be like, "I think they're missing something." Uh
Yeah.
that really
Not
undermines
good.
the process. Does that happen to you, I
Yes.
imagine?
It's happened once, yes.
Yeah. Yeah,
And it
it
makes it
can really
extremely difficult.
it does. But on the other side, how often have you gotten a referral from, let's say, outside of your usual referral base in the movement disorders community, and you're like, I do think there's something else going on here, and you send them for a second opinion somewhere else?
Yes, I love that.
Yeah.
And it happened a couple of times when I was working at the hospital, actually. And that was pretty frustrating, to be honest, too, because
Yeah.
the hospital systems tend to look at PT from a lens of like just kind of taking orders and just doing exercise, and
Right.
like not really being an independent clinician that has a doctorate level education that does have the knowledge and capacity to do this initial like differential, and really our job is to make sure like that the diagnosis is correct when, and this goes
Right. Right.
across anybody, any type of condition. Like you have to make sure it matches up, and if you're seeing signs and symptoms that could suggest something else, you need to get that person to the appropriate physician for further investigation. And so yeah, I've had a couple of people where mostly after surgeries too is the big one
Mm,
of
yeah.
these long history of abnormal, unusual movements that they're kind of just going through the healthcare system. Every appointment's kind of like the patient's talking about their symptoms. The provider's like, okay, you have these, maybe do this test or go see this person, see me in 3 months. And then it like just keeps repeating. And you just get people that have been doing this for years and years and years. And
Yeah.
and to be able to catch that then and be like, okay, these are distractible, that tremor's untrainable, that like all of these things that rule in this diagnosis, and then being able to get them to a movement disorder neurologist that's also one of my favorite parts too of being a PT.
Yeah.
I love that.
Yeah, I think I remember seeing some study that it was approximately like somewhere like 20 to 40% of referrals to movement disorders clinics end up being like functional movement disorders, which to be fair, in the epilepsy clinic, it's comparable
Yeah,
in terms
yeah,
of being non-epileptic events of some stripe or another. So and that's what I always tell people, like, oh, have you ever seen this before? I'm like, yes, all the time. Uh, but that's
yeah,
okay. There's a different treatment plan. We need to, especially like if they're on a bunch of meds, like for tremor, like, on barbiturates, like primidone, which is just making them super sleepy and probably worsening like any sort of dissociative type features they might have.
yes, yes,
Uh,
yeah,
yeah, cleaning up that medication list is, like you said, it's a very satisfying piece of it sometimes.
yes. And yeah, and I'll even kind of refer people back to their physician too to kind of talk about treatments because most people say like I'm on all these medications and I think they're all just making me worse, and I'm like they probably are. So
Yeah.
let's get you to someone that can
Yes.
help you figure that out more.
Yeah. That is a very challenging piece. It yeah, there's a lot of, let's just throw a medication at it and see what happens. Which,
Yeah,
in the first couple of visits, maybe, but
yeah,
eventually it's like, it's not working. Well, maybe we just need more medicine.
yeah,
And that's, yeah, I can see the conundrum if you're not super familiar with some of these problems, but it does become
exactly. Yeah,
frustrating when you come in at the tail end and you're like, oh, this is just a disaster. And yeah, like you said, the education, because a lot of these you can't just stop them cold turkey. You got to kick them
yep.
down nice and slow so you don't put someone in withdrawal. And yeah, it's a whole process getting that in. From your perspective, like when you take on a new client, what's a typical, like let's just say someone with like a functional tremor, upper extremity. What's a typical treatment protocol or like types of sessions? Like how many sessions do you typically do before you usually start seeing improvements in an average person?
So one of the great things about functional movement disorders are you can start seeing improvement day one. And really
That's awesome.
yeah. And so on that initial evaluation day, like one of my main goals is to show this person that they do have the capacity for normal movement and they do have some control over it. That is one of the most important things. And that's typically possible. I mean, most people we're able to do that. So whether
Awesome.
that's even just pointing out to them, when we're doing some type of activity that, oh look, your tremor's gone right now,
Mm-hmm.
like it's completely gone. And a lot of times people have difficulty recognizing that unless it's brought up. And I think caregivers and stuff, family members, sometimes they're either hesitant because they don't want to make it seem like they're telling the person like you don't have a tremor, like if
Right, right.
you have the tremor one time and now it's like you're doing all of these things without it. They don't want to do that, or the opposite end of that, they really hound the person and are like really like you can do it, just keep doing it, like
Yeah,
stop with the tremor and stuff. And so
yeah.
for me to be able to show them that and explain why that is. And that's
Mm-hmm.
really the important piece. It's not just like they can do that because they probably do at some, certain level do know that it's not all the time.
Right.
Although it does feel like that often to them.
Mm-hmm.
They don't know why that is, which can be really confusing. And
Yeah.
being able to explain that in a way that makes sense to them is really that light bulb moment and try to
Gotcha.
get that on that first visit, of starting to normalize movement. But,
Hmm.
and then, over a couple of weeks, you start seeing that people are, because we end that visit with them doing that now for the rest of the week. So it's all about
Hmm.
that repetition, that practice. And over a couple of weeks, they start getting the hang of it. They start implementing these things more and more. And really, it's about using these strategies like during just everyday tasks, not even necessarily like sitting down, 30 minutes, carving out that 30-minute time for to do your
Hmm.
exercises. Like, no,
Right.
you're doing this every day, all throughout the day. I use things like headlamp laser pointers to kind of focus somebody's
Nice.
attention on something
Hmm.
while they're washing the dishes, which allows them to do the dishes without their tremor anymore. Um,
Nice.
Putting a cup down on coasters if they're focusing on a coaster that's a similar size as like the bottom of a cup, so they really have to like focus on that. It's a task really, and it's a
Yeah.
goal. um, and having those all throughout the house. And so it's more about modifying that environment and them doing it all the
It
time.
sounds like a lot of creative problem solving has to go into these types of assessments for FND in particular.
Constantly,
Yeah.
every time, and it's always different, and that's why I love it too.
Yeah, I
It
imagine.
really
Yeah.
does get you thinking,
Never.
and no one's the same. No one.
Yeah, that's never gonna get you bored, I bet. And you,
No.
so you do home assessments as well.
Yeah, so I actually do primarily home, and well, actually, really, I'm kind of more telehealth right now, which
Okay.
has been nice for me. But because I do see people quite far away, like even on Long Island, upstate New
Hmm.
York, and even I'm licensed in New Jersey too, so I'll also
Okay.
see some people in New Jersey. Um, and yeah, and the great part about this is doing telehealth works pretty well also. And we use just
Nice.
everyday household items. But yeah, that or if they're close enough, I'll go to the home, and typically then we'll kind of transfer to telehealth over time.
Nice. Now, do you find is it usually just the client themselves, or do you usually have like a family member or close friend with like in the room with them as well, in case there is any need for hands-on type thing?
It depends. Some people don't want their family member like there at all, which is understandable depending on
Sure.
their relationship.
Mm-hmm.
Other people, yeah, I tell them we really I don't think can do telehealth unless we have somebody there.
Yeah.
Um, so that's variable, but it typically works out. Yeah.
Excellent. So I imagine being the only person specialized in this in such a huge environment, uh, your schedule's probably pretty full up, right?
It is. And yeah, I don't know what to do from here. I'm like, we need
Yeah.
more people doing this.
So,
Just
and I know you said you've been doing lectures for like local groups. Are you part of the faculty at any of like the local PT programs?
I am not, and that has been in the back of my mind, and it's
Yeah.
something I would really like to do.
Awesome. Yeah, it's definitely a very in demand population, certainly. Um, any any hopes to bring on more associates into your practice in the near future?
Maybe we'll
Yeah,
see. Yeah, one of the things is I really have to trust them that they're gonna know like what to
absolutely.
do.
Yeah,
So we'll see. That's definitely not out of the question.
awesome. Yeah, I know it is hard to bring on people when you've built a practice that is, let's just call it your baby, if you will,
Yeah.
and you
Yep.
have the way that you do things, especially when you have, like you said, you've kind of had to go out and learn and figure out what works and doesn't to a large extent. Um,
Yep.
that's amazing. It's really great. And for people in like say other parts of the country, how can one go about finding someone with like a physical therapist or occupational therapist or what have you who is more focused on FND in its various types? Is there any good
Yeah.
resources out there, or not so much?
There's not a lot, but I really like the FND Hope website.
Mm-hmm.
Their provider tool.
Mm-hmm.
Typically, people will be on there. There's also the FND Society. They have a
Yeah.
directory as well, and so people can go on there and look people up as also. We're hoping in the near future here to have a special interest group in the Academy of Neurological Physical Therapy
Oh,
to
nice.
for FND because it doesn't
Mm-hmm.
really fit any of the other ones. And so
Right.
hopefully we start getting that up and running and hopefully start putting providers on a provider
Mm-hmm.
portal also.
Awesome. Has there been any wider advocacy within the PT community in terms of FND and like it maybe
Yes.
increasing its education in the curriculum?
Yes. And one of the biggest leaders in that is a practice out in Los Angeles, reactive therapy and wellness. Um, the owner is Julie Hirschberg. She's an amazing physical therapist. They're all amazing.
Yeah.
PT, OT, neuropsych. They do a lot of education for healthcare providers and for patients.
Yeah.
They have an online mentoring community that I'm a part of too,
Mm-hmm.
and that's been a huge help. So for anyone that is
Awesome.
wanting to do that, I highly recommend having mentoring of people who
Yeah.
have been doing this, for a
Mm-hmm.
little bit longer. And they're a great resource for patients and providers.
Yeah, I do get their email newsletter, which is like you said, it's quite good.
Nice. Yeah.
um, if people want to, or I should ask, any final thoughts, things like say for patients or for other physical therapists out there, and if they encounter these patients, um, what should they be thinking? Like, let's say they get someone who's sent for a tremor, and they're like, I think they might have a functional tremor. How would us, let's say, a therapist, and I'm in a pretty rural area where there might not be like, well, there isn't. Within 60 miles, there's no movement disorder specialist. What would they do for someone in that situation?
That's a good question. Um, it would be really about finding a provider that's open to learning more
Yeah.
about it, and working with them, even if they
Hmm.
don't have this extensive knowledge in it. Um, Listening,
Hmm.
acknowledging, validating is can go a
Yeah.
really, really long way with people
Hmm.
that have gone through so much and are
Right.
currently still going through a lot. Um, and is kind of sometimes hard to find. And so
It really is.
finding a provider that is able to do that and work with them would be
Mm.
the first step and seeing if anything, is if it's going to work. If not, some people do have to, go out of state and go to some of these bigger clinics like at
Right.
Mass General or
Hmm.
Stanford, Mayo Clinic.
Right.
Um, and sometimes that is an option for people.
Gotcha. And conversely, let's say that you're someone with a, let's say, some sort of movement disorder, and you've been told it's potentially functional. You're going through, let's call it, like you said, standard traditional physical therapy, and it's not helping, or it's making it worse. How is there any way that the patient themselves can identify that this isn't helping as much as it should be?
Yeah, I think being, directly open with your physical therapist
Hmm.
and physician, your whole treatment team that, something's not right here, something isn't
Hmm.
working and I want to try something else. Can you
Hmm.
help me with that? Um,
Yeah.
is that can go a long way too. I think, it's that's hard to do also,
Yeah.
from a patient perspective, that can be a very challenging thing. Um,
Right, right. Yeah, there is that, power dynamic to a degree, which, sometimes, yeah, if you get a cranky healthcare provider and they're just like, well, maybe you just need to see somebody else.
yeah, yeah.
Unfortunately, which is not an uncommon situation. Um, but yeah, and I think it all comes back, having more than one tool in your toolbox is really essential for these types of people.
Absolutely. And there are, I forgot to mention, there are expert consensus guidelines too for
Mm-hmm.
PT, for OT, for speech, um, for functional neurological disorders. There's also, some summaries on psychotherapies for people with
Mm-hmm.
FND, and so those are also really, really good resources to look up.
Excellent. Excellent. Well, if people want to find you online, where should they look for you?
Yeah, they can go to my website, rewire-pt.com.
Mm-hmm.
They can reach out to me through there. Hopefully, I'll be, once I get some time, hopefully updating
Yeah.
that and getting some more content out. Um, Also, follow me on Twitter. Twitter is Zachary Grin DPT. On my Instagram is RewirePT. Yeah, and I hope to be providing a lot of content out there to start educating more and more people.
I've certainly found your treatment videos fascinating. It's not something
I'm
on the
glad.
physician side that I get to see in person very often. So
Yep.
it's always amazing to see people who, like you said, we're having so many difficulties with something as simple as walking a flight of stairs. Doing, I thought that one where you had the young woman walking down the flight of stairs, quite
Yeah,
amazing. That was great.
it
Um,
was. She's doing awesome.
and yeah, and do people need a referral to come and see you, or do you take self referrals as well?
So in New York, people can come to me and I can do an
Hmm.
evaluation, but then to treat, we do need I do need a referral. But
Mm.
people can just reach out and I can get them scheduled, and then I work with them to work with their physician, whoever it may be. Sometimes it's just a primary care to get that referral.
Well, thank you so much. I really appreciate you taking the time to talk with me. This has been very educational for me as well.
Yeah, thanks for having
It's
me.
such a unique niche, especially in the physical therapy sphere, and I really appreciate it.
Yeah, yeah, I really appreciate you for having me. Thank you so much.
Thanks. Thank you, everyone, for listening. If you enjoyed this podcast, please rate, review, and share it on Apple, Spotify, or wherever you get your podcasts, and please subscribe for future episodes. You can reach me on Twitter at Dr. Kentris, that's DrKentris, or by email at theneurotransmitterspodcast@gmail.com with any questions or show suggestions. We'll see you all next time.